because the manifestation of the DVT, deep vein thrombosis, sort of it becomes apparent, and the clots start getting dislodged after 5 to 7 days. So not on the first day. So pulmonary embolism is a late pulmonary complication following major surgery. And you have to know about the predisposing factors like obesity and then prolonged immobilization, previous history of pulmonary embolism or DVT, and then females being on hormones, um, uh, anti-hormones, and then hormonal therapy, and also pelvic surgery and malignancy. These things you should have them in your fingertips, the predisposing factors of DVT. So, but anyway, pulmonary embolism in this case is unlikely. It's a relatively rare complication, not on the first day. So, sepsis can cause all this hypotension and shock status. But it is kind of unlikely, this type of abdominal surgery, to come within first 24 hours. Unless the patient had an emergency surgery, like say bowel perforation or unprepared bowel is being operated, or that sort of emergency abdominal surgery, sepsis, the endotoxin and the bacteria can enter very fast, so that sepsis can occur very early. But this is an elective surgery, anterior resection. So in elective surgery, sepsis, especially when the elective surgery is covered with prophylactic antibiotics, so routinely, when the bowel and biliary tract and urinary tract are involved. So under those circumstances, within first 24 hours, sepsis is a unlikely cause in this particular case scenario. But if it was a emergency abdominal surgery, sepsis is quite a possibility. Unresolved pain generally will give rise to neurogenic kind of shock, if at all. But generally, they are not, they don't become hypotensive as such. And also, even there's hypertension, neurogenic shock is generally associated with bradycardia. So, and it is unlikely in this situation. So, for these reasons, hypovolemia is the best answer. 40-year-old male presented to emergency unit with blunt trauma to the chest. If you have done this, just stop me. He was found to have a flail chest. What is the most appropriate pain management? Any attempts?
Epidural analgesia.
Epidural analgesia, yes, a possibility. So why are the others? Why others not so correct? Endotracheal intubation and ventilation.
There's no need for that yet, sir.
Actually, in a large flail segments and flail chest, that is kind of a treatment. Endotracheal intubation and ventilation, especially positive pressure ventilation, to keep the flail segment moving and causing paradoxical breathing. So that is a treatment modality. But question is on pain management. So by just doing endotracheal intubation, that is a treatment. It may not be the best, because anyway the chest wall is going to move, and these fractured ribs are going to cause a lot of pain. That is the reason why endotracheal intubation and ventilation is not the best pain management. Okay. Generally, this endotracheal intubation is generally done when there is low PO2 and then signs of respiratory failure or hypoxia. Okay. So, and also if you are suspecting a significant underlying pulmonary contusion. So, but all are right if it comes to treatment, but not for the pain. So that is not the best answer. Epidural analgesia is quite a possibility. That is the best type of treatment. Why is it the best type of pain management?
Because we can load up more.
Yeah, top-up doses, yes. You can repeat the analgesia. You give epidural morphine. You can repeat the doses and then keep the patient pain-free. So that is the biggest advantage because you have the epidural catheter in this space. Epidural analgesia is the best way to treat rib fractures and, in a way, rib fractures and chest injuries. And then paracetamol and diclofenac sodium. In the pain ladder, these are paracetamol is, of course, low down in the pain ladder, WHO pain ladder. Diclofenac is high up, but then again, for these rib fracture pain, these may not be adequate. And intercostal block.
The effect will wear off after some times.
Yeah, it's a temporary relief. There is no continuous analgesia like in epidural analgesia. You can't top up because we can't keep on injecting the intercostal nerves. So that is not again one of the best way of managing this. So patient-controlled analgesia.
Usually we use morphine, and there's a risk of respiratory distress.
Yes, sometimes overdose is a problem. And then when it comes to trauma, the patient-controlled analgesia is basically for the terminally ill patients and then for cancer pain and palliative care. Because let us say there's severe bone pain due to secondaries. Then, of course, patient-controlled analgesia with the diamorphine pump is one of the recommended treatment. But when it comes to trauma, it has been shown that patient-controlled analgesia is not the best way to keep a continuous control of pain. So that is a less suitable answer for this. So best answer will be B. So rib fractures and chest, flail chest and rib fractures is the best type of analgesia. 78-year-old male underwent transurethral resection of the prostate, 50 minutes. Immediately after surgery, developed drowsiness and confusion. Normal respiration, vitals were stable. What investigation finding will describe this situation best? When you read this type of a clinical scenario, at the end, you should get some idea about what we are talking. What is the clinical scenario here?
Post-TURP syndromes.
Yeah, TURP syndrome. Yeah, TURP syndrome, because one of the early symptoms of TURP syndrome is water absorption, that is fluid absorption and hemodilution, leading to hyponatremia. And then one of the early symptoms is confusion, and drowsiness comes a little later, but confusion is one of the early symptoms due to early cerebral edema. And later on, there will be fluid overload leading to dyspnea and pulmonary congestion and pulmonary edema. And as a little late complication, you get hemolysis leading to hemoglobin releasing into the plasma and clogging or blocking the kidney, that is tubules, and then leading to the free hemoglobin is toxic and leading to renal failure. So in that order. So first the confusion, then comes the heart failure. Then later on, if it's not corrected, this confusion will lead to drowsiness and coma, even coma. So these all happens due to hemodilution. And best way to detect hemodilution is, what do you think the best way to?
Hematocrit, sir?
Yes, I think it sounds reasonable, but hematocrit can be due to bleeding and hemodilution due to the saline given. Fluid resuscitation. So suppose this is a large prostate, it bled a lot, and then anesthesia has given a lot of free fluids, that is crystalloids, before blood is available, then that can cause low hemoglobin, not necessarily TURP syndrome. So low hemoglobin during or after, just after TURP could be due to hemodilution secondary to TURP syndrome, or it can be just hemodilution due to overload of crystalloids. So that both can happen. So hemoglobin is not going to be the best investigation to find this situation. PCO2 and PO2, that means hypoxia and carbon dioxide retention, shows that there's some sort of a respiratory problem and pulmonary edema, but that is not specific for TURP syndrome. It's not a specific finding. Suppose there is some sort of hypoventilation, one lung anesthesia, anesthetic problems. So anything can cause this respiratory problem. So it is non-specific. Serum glucose is within normal limits, so it's not going to help. So crucial one, TURP syndrome, the crucial investigation is serum sodium. If you are suspecting TURP syndrome, first thing you must do is the non-drip hand. Now, when the drip is going on, you should not take blood from that. From the other arm, you have to take blood for serum sodium. If it is below 120, it is called severe hyponatremia, and then that is a classical feature of TURP syndrome or hemodilution. So the answer will be serum sodium. So somebody is talking about TURP and confusion and problems, always think of TURP syndrome. And sodium is the crucial investigation. And okay, 50-year-old woman presented with weakness in extension of left wrist and fingers. She has sustained a left humeral shaft fracture following car accident 1 month ago. What is the most likely structure involved? These are relatively easy ones. MCQ.
Radial.
Yeah, obviously radial nerve, because this is a wrist drop, and this is called tardy radial nerve palsy or late radial nerve palsy. Secondary to, now this has come after a month ago. So what happens is when the callus, yeah. Sorry? Hello? Yeah. So there's any questions, or if just ask. So other things, like brachial artery injury will give immediate distal ischemia, and you will get paresthesia, numbness, and inability to move fingers or flex or extend. You get the signs 6 Ps in brachial artery injuries. So that is not mentioned there, and which is very unlikely with humeral shaft fractures. Brachial artery injury takes place with supracondylar fractures. Brachial artery, supracondylar fractures are not mid-shaft fractures. And that will be an immediate problem. If you delay it in treating, you will end up in Foxman contracture. Foxman, some people pronounce it as Voxman, but actually it is pronounced as Foxman contracture due to ischemic contracture of the flexor compartment. So that is the outcome of brachial artery injury. So which is not the correct answer when it comes to this question. And median nerve is also unlikely, though median nerve can be involved in, again, supracondylar or low humeral shaft fractures. But again, the signs will be different, because you will get these failure to flex the fingers and the flexion problems with paresthesia on the lateral 3.5 fingers. And you will get this classical sign you should know, the sign of benediction sign, where the patient can't bend the lateral 2 fingers when he's asked to do that, so he always keeps it up. So know these basic things about median nerve injuries, because next time the stem may be of one of these injuries. Profunda brachiae artery generally is a very deep artery, and it doesn't give rise to much inability, uh, uh, disability or inability to move the structures, because a lot of anastomosis is there. So it supplies the posterior part of the arm. So it's nothing. There's nothing to do with the wrist, because the distal circulation doesn't get involved in profunda brachiae artery, because it's compensated by anastomosis and collaterals. And radial nerve is the correct answer, wrist drop. And ulnar nerve palsy will give rise to ulnar claw. And there's again that thing called tardy ulnar nerve palsy, where tardy means late. Late ulnar palsy, where you end up in ulnar claw. Ulnar claw, which is that medial 1.5 fingers will be, there'll be paresthesia in that, plus there'll be claw fingers of the medial 2 finger. So that's called ulnar claw, and that is due to the paralysis of lumbricals. So these features, I think you must revise a little bit, because it is common to get 1 or 2 questions on these nerve palsies, upper limb nerve palsies. So D, 20-year-old obese man underwent laparotomy for perforated peptic ulcer. He develops tachypnea on the post-op day 1. On respiratory examination, right lower zone has reduced air entry. PO2 has gone down 78%. What is the most likely cause for his hypoxemia? Any idea?
Lower lobe pneumonia.
Lower lobe pneumonia. Okay, that's a possibility. But this is, remember, this is very early. It was 24 hours. So lobar pneumonia will take little time, because there should be retained secretions, and then there should be either obstructed bronchi or retained secretions leading to lobar pneumonia, and patient has to be immobilized for some time. So generally, lobar pneumonia come after 48 hours, 2 days, and associated with fever and sputum, purulent sputum. This is just a tachypnea. So
Vasoatelectasis?
yes, I think that is the most likely, because first 24 hours, if the patient finds this difficult to breathe or dyspneic, and also his saturation goes down, it is due to collapse of the basal alveoli. That is called basal atelectasis. They are collapsed and they are not expanding. So there will be a ventilation fusion mismatch, because our blood will be supplied to that part of the lung, but it is not getting oxygenated. It just go past those alveoli which are collapsed. So that is why they get this low PO2, and generally it is bilateral, but it can be unilateral, as this mentions right lower zone, reduce air entry. So basal atelectasis is the most likely answer due to this first day. And low hemoglobin, again, anemia can cause hypoxia, but laparotomy just after 1 day, the first day itself, anemia causing dyspnea or low PO2 is very unlikely. And generally, so that also comes little late. So low hemoglobin, so that is unlikely. Pleural effusion, pleural effusion is also a possibility, but then it says that there is low air entry, but nothing mentioned about dullness. So percussion dullness, and generally that feature has to be there. And again, effusions are not likely. on the first postoperative day following abdominal surgery. Suppose this surgery involves closer to diaphragm and there's a diaphragmatic perforation like kidney surgeries, then of course fluid can enter on the first day. But otherwise, these are called sympathetic effusions. Following abdominal surgery, they come after 24 hours. So pleural effusion is also unlikely within first day. And pulmonary embolism, again, as I mentioned earlier, is after 5th day or so. So it is timing is the most important. Most of these other responses come rather late after a major laparotomy. So basal electrophoresis is the correct answer. 67-year-old male, a chronic smoker, presents with painless gross hematuria, urine cytology shows atypical urothelial cells, papillary tumor on the lateral bladder wall, CT shows no upper tract involvement, but muscle invasion is reported in pathology report. What is the next best step in management? What should you do? Any suggestions?
Radical cystectomy with urinary diversion.
Yeah. Okay. So that is a possibility. So why the others are wrong? Why not
The
intersect?
first one, we are not giving BCG for muscle invasive ones.
Good.
And transurethral resection has already done, because that's why we got the muscle invasive, this pathology report.
Yes.
And systemic chemotherapy alone, it's not enough, because now it's already muscle invasive and partial cystectomy and adjuvant.
Why do that?
That we can try that.
Okay, that's possibility. Yeah.
Yes.
So principles you have to know in this case is that, as you correctly mentioned, intravesical bacillus BCG is only for superficial bladder cancers, non-muscle invasive bladder cancers, because this therapy doesn't go into the muscle level. So if there is muscle invasive bladder cancer, BCG or in that case intravesical therapy, mitomycin C is the other one, that is intravesical chemotherapy, or this is called intravesical immunotherapy, BCG. Both are not for muscle invasive bladder cancers. So that should not be considered. And then radical cystectomy with urinary diversion top in the cards, because any muscle invasion, even though you see only a small papillary tumor or a sessile tumor in the bladder, once the muscle is invaded, there are very heavy lymphatic net in the bladder muscle. Because as you know, there is no suburothelial low, just under the epithelium, there is no lymphatics. Because if there were lymphatics, all urine would have got absorbed. So because there is no lymphatics just under the epithelium, all the lymphatics are in the bladder wall. So moment the cancer invades the bladder wall, it spreads beyond the macroscopic appearance, it spreads into the bladder muscle. So actually speaking, though you see a small mass there, which you will do a TURBT and remove, rest of the muscle is also involved. So that is a malignant bladder and you are not supposed to leave it, because definitely there will be recurrence. So transurethral resection alone and just surveillance means monitoring will not help for this reason, because transurethral resection will remove only what you see, the macroscopic tumor. But as I was mentioning, this tumor has gone into the rest of the muscle as well along the lymphatics. And systemic chemotherapy alone will not help, because that is not going to completely eliminate the tumor. So chemotherapy alone is not a curative therapy. Always chemotherapy is, except in hematological malignancies like leukemias, chemotherapy in surgery is palliative. You must remember that principle. And chemotherapy can be given before surgery, before bladder tumor surgery. to reduce the size of the bladder tumor, shrink the bladder tumor, and then avoid local recurrence. So that is called neoadjuvant chemotherapy. Or else, you can give it after surgery, after removing the bladder, if it comes, the bladder and the lymph node, if it comes positive. There is a possibility that there are microscopic deposits which we have missed. Then adjuvant chemotherapy can be recommended, but not in all cases. Partial cystectomy is not done due to the same reason that though in partial cystectomy we can remove that part of the tumor with the part of the bladder, there always can be at the edges, you can get the tumor. And for that, if you give radiotherapy, that is why the combination, partial cystectomy, and for rest, you feel as if you can give radiotherapy. But it has been clearly shown that if you don't combine radiotherapy with chemotherapy, that's called chemoirradiation, the treatment is going to be incomplete. So E is wrong because one thing is partial cystectomy is considered in very rare occasions. And only for adenocarcinoma, only for isolated adenocarcinomas, you can consider partial cystectomy. But for urothelial carcinomas, partial cystectomy is not a recommended treatment. But translucent resection in very small tumors, muscle invasive tumors, you can do translucent resection, and for the rest of the bladder, you can give chemoirradiation. If you are treating it, you have to give chemoirradiation. That is called the trimodal therapy. Trimodal therapy in a selected group of patients who have very small bladder tumors. That's only a minority of people. So remember that if we say it's only about half centimeters small muscle invasive tumor, and response is there, TURBT with chemoirradiation, that is the correct answer. So, but when it comes to general guidelines, radical cystectomy with urinary diversion is the correct answer for muscle invasive bladder cancer. So answer will be B. Alone, chemotherapy or radiotherapy has no place. Surgeon wants to do a histological assessment, sentinel node, best method to transfer the specimen. Any idea, guesses? I'm sure some of you all would have seen this being done. These are all kind of preservatives preserving solutions we send biopsies in.
10% formal saline.
Yes, formal saline. So why the others are wrong? Why not saline? Just, yeah.
It can destruct the cells.
Yes, actually saline doesn't preserve tissue. So because when you send it, sometimes it might take a day or two for the pathologist to report. So as you said, that there can be distortion when you put only saline because you have not fixed the tissues. And only for fresh frozen sections. Fresh frozen sections and the imprint cytology or fresh frozen section, while the surgery is going on, you want to send a small piece for checking after informing the pathologist that you are sending it. For that you can use saline because it is sent very fast and then report will come very fast. So saline is used for fresh frozen sections. Ethanol. Why not ethanol? Yeah.
It's mainly used for cytology. So.
Yeah, ethanol is used for cytology because if you send tissue samples, what will happen? Tissues shrink. When in absolute alcohol, tissues shrink and then architecture become distorted. So cytology, like the pap smears or urine cytology, you can use ethanol, but urine cytology is a different because you have to send a large specimen of urine. So ethanol is not, formal saline is standard for this type of biopsy, all solid tissue biopsies, because that one thing is it fixes the tissues. Number one is by changing the protein nature, denaturing the protein, it fixes the tissue, so architecture doesn't change. And it will also prevent, it's like embalming, so it will prevent autolysis and even bacterial degradation. That's the advantage. And the morphology is preserved. So 10% formol saline is the standard solution. Phenol is only for cleaning operating theaters. Okay, floors, so not for tissues. And dry sterile container, dry specimens only for if you are checking, say, if you are sending it for culture and ABST any specimen, then dry sterile container is what is used. But other than that, this type of soft specimens, you don't send it dry. So no other uses of other preservative techniques. And antenatal ultrasound shows fetal hydronephrosis. 1 week after the birth of this baby boy, he was found to have bilateral hydronephrosis, hydrourethra and thickened pulmonary bladder wall. Most likely diagnosis?
C, sir. Posterior valve.
Posturethral valve, C, isn't it? Okay, why not
Yes,
meatal stenosis? Why is meatal stenosis wrong?
The meatal stenosis presents a bit later, and the thickened bladder wall and bilateral hydronephrosis is less likely, sir.
Yes, but both will cause outlet obstruction, isn't it? Posturethral valves also won't allow the baby to pass urine in utero, so that builds up a intravesical pressure and cause the bladder wall thickness. And also later on, reflux or uretrovesical junction obstruction will lead to hydronephrosis. So that can happen with any outlet obstruction. So why meatal stenosis is wrong? Because meatal stenosis and urethral strictures, urethral obstruction, the main obstruction, the main pressure of the obstruction is taken by the bladder. So what happens is that also doesn't happen immediately. And when you have, even in adults, meatal stenosis or urethral strictures, bladder will, after some time, it will get hypertrophied. But it's very rarely you find that this pressure is transmitted to the upper tracts. So that is the reason meatal stenosis is unlikely. So because the upper tract dilatations are generally due to a bladder neck, like in adults, prostato bladder neck hypertrophy, or in children, few valves. So remember that is the difference. Neurogenic bladder, why that is unlikely?
It's a mostly it can be a mostly secondary cause, sir. And in the neurogenic bladder,
In particular case,
the thickened trabecula is not there. It's like
yes.
flaccid.
Yes. Why is that? Because neurogenic bladders occur secondary to spina bifida. And spina bifida generally involves the cauda equina, that is the peripheral nerves. When the peripheral nerves are involved, you end up in a lower motor neuron type of bladder. Lower motor neuron type of bladder. So low motor neuron bladder is involved, big capacity, low pressure bladder. So just know that. So a neurogenic bladder in children and even in utero or infants is generally secondary to spina bifida, and that causes a large capacity, fully empty bladder, but not thick, so thick wall bladder. So that is very unlikely in this case. Posturethral valves is a straightforward answer for this. And primary vesicurethral reflux, primary, is due to malfunctioning of VU junction, vesicuratic junction, sphincter mechanism. And it can give rise to dilated upper tracts, but will not give rise to any bladder wall thickening. Bladder wall thickening means there are some sort of a bladder outlet obstruction. So due to that reason, this is unlikely. And VUG obstruction, again, for same reasons. Generally, VUG obstruction leads to unilateral hydronephrosis. If there is bilateral hydronephrosis, always think of a bladder outlet, again, bladder outlet problem, or a vesiculatic reflux. So VUG obstruction is generally unilateral. Right. The 65-year-old retired teacher has intermittent arterial claudication, both calves walking 500 meters. Able to perform his daily activities, he is on aspirin and statins. Most appropriate adjunct for his management. So it's kind of next step in his management.
Walking exercises, sir.
Why the others are wrong?
He's in Fontaine
Fontaine.
2A. Fontaine
Yeah.
2A.
Yes.
So we can walk and develop his collaterals.
True. That is again why he is going to be the correct answer. Why the others are wrong? Why not angioplasty and stenting?
The Fontaine is not advanced enough for, so 3 and above is for intervention.
That's right. So it is, if it is Fontaine 3 or more, say severe lifestyle limiting type of claudication, or there is signs of critical limb ischemia, like rest pain or early ulceration, discoloration of skin, then of course you have to think of correcting the obstruction surgically or interventional radiologically. But this type of Fontaine 1 or 2, you don't go for that sort of a involved procedure. So angioplasty and stenting is wrong because of that. Cilostazol. What is cilostazol? Not very commonly used, but can be used. It's kind of a prostaglandin inhibitor, which leads to nitrous oxide release and vasodilatation. Something similar to Viagra or what is given for erectile dysfunction. It's a vasodilator basically, but it improves the clinical symptoms, so claudication symptoms. But after exercise only, if they don't improve, you can try these medications. So that is not the first line. Next best step for this man. Isosapine mononitrate.
Not the
Not,
first.
yeah, not even it's not in the guidelines even. Actually speaking, isosapine is for coronary events and coronary thrombosis. So it is for angina and coronary syndromes, but not for peripheral artery disease. So it doesn't improve. Has been shown in clinical practice that it doesn't improve claudication symptoms. This isosapine, though it is a vasodilator. Theoretically, it is possible, but not practical. Not practically, it's not doable. Clopidogrel. Why is it wrong? It is similar to aspirin. So more or less, what they have shown is that it doesn't improve. It doesn't provide additional benefit if you are already on aspirin. So that will cause thrombasthenia and prolonged effect on poor quality platelets. But then what studies have shown is that while he is on aspirin, for this type of mild cases, adding clopidogrel is not going to have any beneficial effect. So that leaves the walking exercises or graded exercises, what you call, gradually increase the walking distance and respect the controls like statins, giving statins and aspirin, smoking cessation, and controlling like diabetes and hypertension. All these things are the first line treatment for Fontaine A, Fontaine 1 and 2. So correct answer will be E. During renal transplantation, transplanted kidney turned dusky immediately strictly following vascular anastomosis despite successful vascular approximation. So good job is done, good surgery is done, but then suddenly it becomes dusky, that is purple in color and dark in color. So later the graft nephrectomy was also done. What's the most probable cause? It's of course, yeah.
B, sir?
I would think it's acute cell-mediated immune response. B, yeah, possible. They all are possible. Sorry. Yeah, take one by one. Acute antibody mediated, this type of difficult ones in the sense that you are not very familiar with this. Take one by one, and by exclusion, you might get the correct answer. Acute antibody mediated immune response. Why do you think? Yeah, sorry. Yeah, you're right.
Takes time, sir.
Yeah, it takes number of hours, not immediate. It takes sometimes half a day, or sometimes end of the day, you suddenly find that kidney become dusky and its circulation is impaired, and sometimes a few days, 3 or 4 days. So it's hours to days it takes. And B, acute cell mediate, as you know, immunology, cell mediate immune response occurs after days or sometimes even weeks. So antibodies will attack the transplanted kidney in few hours or days, and the cell-mediated immune response destroy the kidney after days or weeks. So this is immediate. So those first two answers are not going to be the right ones. And acute tubular necrosis, again, this happens little late. Initially, the graft functions very well, but it doesn't cause in this type of dusky discoloration. The moment it says dusky discoloration, you have to think of a vascular event. Something has happened. Nicely, the vessels are joined, but something has happened to the vascular bed. So, acute tubular necrosis will lead to oliguria after, say, sometimes few hours or few days, and the graft function will go down. And this color change will not happen. There is no color change. Graft versus host disease. Why is it wrong?
It's a really late complication, sir.
Actually, it doesn't happen in solid organs like liver, lung, pancreas, kidney. The graft versus host disease reaction is generally a bone marrow. It happens in bone marrow transplants, and it is not very well described in solid organ transplant. So because of that, graft versus host disease. Because in bone marrow replacement, you know that there is a lot of immunological cells involved in the bone marrow. So, but it doesn't happen in solid organs. So that is wrong. So that leaves us with the renal vein thrombosis. So here what happens is that sometimes it can happen. So after a very successful transplant, the vein can get thrombosed. It can be, most of the time, the reason is not very clear. And then what happens is once it is thrombosed, many occasions the graft will die then and there. So there is no way of relieving it because some of these thrombi are not removable. So renal vein means there are branches of renal vein. The whole renal vein system gets thrombosed, and then you get this dusky, dark violet color discoloration. So it happens immediately and generally ends up in, as it is mentioned here, graft nephrectomy. You have to remove the graft. People sometimes try to salvage the graft by giving heparin and trying to salvage it, but many occasions it will end up in nephrectomy. 23-year-old boy admitted to casualty ward with a run-over injury. He is conscious and rational. Chest X-ray shows air fluid level on the left lower hemithorax after ND tube insertion. It curved upwards to the left lower thorax, and what is the most appropriate management? Any attempts or suggestions? Yeah. What do you think this clinical scenario is? This is, and after, when you do a chest X-ray and you see a air fluid level, first diagnosis comes to your mind is pneumothorax, isn't it? Left lower hemithorax. So first thing is not anything else other than pneumothorax. Okay, but he is conscious and rational. But the second sentence is the one which gives the clue that it shows the air fluid level, and then after NG tube insertion. The NG tube has not gone to the stomach, but it curves upwards towards the left thorax. It is coiling inside the thorax. This we see not very commonly, but in the accident service, especially compression injuries on thorax or sometimes abdomen. Runover injuries are classical to give rise to this situation. So what do you think this clinical scenario is? Any idea? It is a
Esophagus has to be damaged, like
yeah, but
achilles and
esophagus
cardiac.
is a very deep-seated structure. Very rarely a external compression or external injury will damage the esophagus. So this is what has happened is when the intra-abdominal pressure goes up due to runover, the diaphragm ruptures. And there are rents can come in thin areas of the diaphragm posteriorly or sometimes anteriorly, posteriorly especially, and then all the bowel or the stomach especially, which is very close to the left. That's why it's given left. In the left, it is found in the left hemithorax. The stomach goes into the stomach, the thorax, through the diaphragm. So that's called a traumatic diaphragmatic hernia. So when you put an NG tube, you will find that if you are suspecting that, especially if sometimes you hear gurgling noises when you listen to the chest. When you listen to the chest, instead of respiratory sounds, you will see gurgling, bobbling by or bowel sounds. So if you suspect that, what you should do is gently put an NG tube, and the NG tube is coiling inside the chest, then it's very likely to be a diaphragmatic hernia. So that is the situation here. What is described. So what is the treatment? Appropriate management.
NG tube insertion, keep needle by mouth and send for surgery.
All done. All done. Now, only thing that you have to select the answer from this plot.
Laparotomies?
So, definitely it has to be operated as an urgent or emergency case. So, IC tube insertion will be done at the end of the surgery, not immediately, because stomach is inside the chest. And observe and monitor is out, completely out, because that will ultimately end up in having pneumothorax, and then also sometimes this bowel, the stomach, the fundus of the stomach even can get compressed and undergo gangrenous changes. Long time ago, one of the very leading thoracic surgeons died of this injury. He was a thoracic surgeon. He diagnosed it himself. His photo is hung on this thoracic unit. If you go today now, National Hospital, he had this, but nobody diagnosed it. So he himself diagnosed that, and then it was too late. He ended up he was taken to England, those days, but he died. So just remember that fun story. But immediate surgery is there. No point doing peritoneal lavages and things like that. Out of that, you have to decide whether laparotomy or thoracotomy is the correct answer. Why not a thoracotomy?
The lungs are there, sir. It's not a good approach.
Yeah, because you don't know. I mean, you can just open up the chest and push the bowel down, but we don't know what is the rest of the abdomen. What sort of injuries are there? There may be other mesenteric vessel injuries and then other bowel perforations. So because of that, unless there are signs of cardiac tamponade or major chest trauma, again you will start by doing a laparotomy. Reduce the bowel into the abdomen and then close the rent or the rupture of the diaphragm from below. And then definitely we have to put a IC tube separately because that lung is collapsed. Left lung is collapsed. So that's the treatment. So laparotomy is the answer, not thoracotomy. Okay. Now there are some supportive pictures here where the rupture occurs. Now this is the appearance you get from the axial surface pictures, right? True false regarding 30-year-old woman presented with long-standing goiter with high T3, T4 levels. Yeah, we can rush through these things. True false, again, commonly convert to malignancy. True or false? 30-year-old woman presenting with long-standing goiter with high T3, T4 levels.
False.
Yeah, that is false. Why? This situation looks like what?
Graves.
Yeah, Graves' disease for primary thyrotoxicosis because it doesn't say multinodular goiter and it's a young woman. So it's a classical appearance. So commonly convert to malignancy is wrong because not only commonly, it doesn't have a risk of getting converted to malignancy at all actually. But if you have a long-standing multinodular goiter, cancerous changes can take place, but that is not determined by the presence of the goiter itself. Especially in primary thyrotoxicosis, there is no such risk. So that is wrong. Exophthalmos is a characteristic in Hashimoto's thyroiditis.
False. That's Graves.
Or, yeah, that is Graves' disease. You get lid lip retraction and exophthalmos and ultimately proptosis. So that's called thyrotoxic ophthalmoplegia. And then sometimes the eye muscles also get paralyzed due to antigen-antibody reaction and presence of edema in the orbital edema. So you can get ophthalmoplegia. Those are the eye changes. Those all come in primary thyrotoxicosis, but not in Hashimoto's. Can present with chronic diarrhea.
True, sir.
Yes. Actually speaking, thyrotoxicosis is a well-known feature because of the intestinal hurry or these increased thyroxine levels cause the increased peristalsis and often cause diarrhea. And sometimes it can go on for some time. And then proximal muscle weakness is a well-known feature.
Also, that hypothyroidic feature.
Proximal muscle weakness, there is thing called thyrotoxic myopathy, and that affects the proximal muscles. So like the thigh muscles and shoulder muscles. So it's a well-known thing like tibial myxedema and eye signs. The thyrotoxic myopathy is described, well-described complication of thyrotoxicosis. So is a known feature, but the thing is that whether it is common in Graves' disease is not very clear, but it can happen. So I would mark it as true. Because it's a well-known feature with thyrotoxicosis. That's called thyrotoxic myopathy, proximal myopathy. Propyl thiouracil is the drug of choice in first trimester of pregnancy.
True, sir.
Yeah, it's very true. because the other like methimazole or carbimazole can be teratogenic. Because of that, those can be given in late trimesters after organogenesis has taken place. But the safest drug is PTO profile thiouracil. And but only thing is always remember that PTO can cause hepatotoxicity. Because of that, in late trimesters, third trimester or so, carbimazole and methimazole are preferred. But first trimester definitely is PTO. So that's how it goes. 30-year-old male presented to the extension service following fall from height 20 feet, GCS 1515. Pulse rate is high, BP low, is quadriplegic with sensory loss of 7-8, lacks anal sphincter. So he is on a spinal board with a hard cervical collar. Most important next step of his management. What will you do? Now, what is the clinical scenario here?
Spinal cord injury.
Yes. Spinal cord injury, high spinal cord injury. It's called a high spinal C7-8. It leads to tetraparesis or quadriparesis. And as we said here, mentioned here, and sensory loss below that. Lax anal sphincter is also a sign of high spinal injury. And now his pressure is low and pulse rate is compensatory tachycardia. So BP is, but he's conscious and rational. That means there's no head injury as such. So this type of shock situation, what should we do? Because it's low
Fast scan
pressure.
of abdomen.
Okay, that can be done. Yes. Why are you doing a fast scan?
Because there can be any underlying abdominal injuries. That's what calling hypo.
Yeah, that's right. So hypotension and tachycardia can take place secondary to intra-abdominal bleeding. So that's the worst part is that can be masked by the loss of sensation and pain. So that is a very dangerous situation. But in this MCQ, I think they should have given little more information. One sentence saying that the abdominal examination doesn't show free fluid or something like that. It's a bit of an unfair question. So the hypovolemia is unfair for the best of 5. But this is true false if you say this is a good question. But then, of course, the person who has said this question is most probably aiming for you to diagnose the neurogenic shock. So it is little postgraduate to think of associated intra-abdominal bleeding, which can happen at the same time. So, well, because there is nothing to exclude that. So when it comes to that, the fast scan of the abdomen, okay, is also right. So what only thing is that we have to select what is the best or next step of his management. So management of this shock state. So fast scan you can do, but this association with the intra-abdominal bleeding and neurogenic shock is not a very common one. But always we have to be aware of it. As a trauma surgeons, we are always aware of it. But it's a kind of a extended thinking. So if you think straightforward manner, this is neurogenic shock.
So
And
because neurogenic shock does not respond to fluids, we should start inotrope.
Yes. So that is one thing. So why start inotrope or vasoconstrictors? So ideal, it should have been called, I don't know, more than inotrope, vasoconstrictor, peripheral vasoconstrictors. Why should we give that for neurogenic shock?
The homeostasis is not work. The compensatory mechanisms won't work in the neurogenic shock.
Why? What is the biggest, why do they go into shock? Why is this BP low? There is sympathetic, there is a sympathetic blockage. Sympathetic outflow get blocked and there's a massive peripheral vasodilatation. Sympathetic cause vasoconstriction and there is uncompensated effect will lead to massive vasodilatation. So there is a distributive shock. This is a kind of a distributive shock, like in anaphylaxis and sepsis. So there's peripheral vasoconstriction, and however much you give fluid, you try to resuscitate them, that fluid get retained in the periphery. So the pressure, it will not help to bring the pressure up. So best way to do that is to give either inotrope or peripheral vasoconstrictor. So out of these three, generally it is noradrenaline is the lifesaver, noradrenaline. But you can give phenylephrine or propainotropes if the renal function is not good. You can give dobutamine or dopamine. But out of that, preferred drug is noradrenaline. So that will increase the pressure. So all the other things are done later, like CT scan of cervical spine, taking MRI of the spine to diagnose. These are not priorities because now he's running at a very low pressure, and that can lead to secondary effects like renal failure, acute tubular necrosis, renal output, the urine output can go down. So that can lead to many problems. So repair the spinal cord injury is, I think, it's a kind of a distractor, which is not a very good distractor. Nobody is going to operate him immediately. But CT and MRI at a later date to get the details of the injury. And fast scan is, if it's a true or false answer, that may be true. Because to exclude concomitant, masked or hidden abdominal bleeding, intra-abdominal bleeding. Or at that case, extended fast scan can detect the hemothorax and cardiac tamponade as well. Ordinary fast scan is only for abdominal fluid, but extended fast scan, e-fast scan is for other two as well. So that can be done. But then what their aim is to find what is the management point. So management generally includes investigation and treatment both. But I think what they are gunning at is what is the most important management point in neurogenic shock to prevent or counteract the peripheral vasodilatation. So answer will be vasopressors, that is noradrenaline, no dopamine.
Excuse me, sir.
Yeah.
So in neurogenic shock, they get peripheral vasodilation and bradycardia, no, sir? Because of sympathetic, the parasympathetic overdrive.
That's true. I think so. That will again can exclude intra-abdominal bleeding, but not always. Not always, because if you have yes, in quadriparetics.
So now in this question, the main
Yeah.
doubt is to exclude bleeding and neurogenic shock. So I
Yes.
think pulse is the main thing.
Pulse is given for that, I suppose. Yes, you are
Yes,
right.
sir. Now here the pulse is tachycardic, but
Yeah.
so
But
then it should.
tachycardic means you are again speaking against the rule, no? And neurogenic shock, it should be bradycardia, no?
Yeah.
If you take only this thing. But the thing is that there will be always compensatory. Now, when there is low blood pressure, there will be kind of compensatory tachycardia. So, because the cardiac sympathetic output, unless it is a total spinal injury, nothing is, completely gone. So, because of that, just looking at the pulse rate, we can't say whether it is intra-abdominal bleeding or BP.
So now
Yeah.
we can't compensate it because sympathetic is not there no? In the neurogenic shock, sir.
Yeah.
When the blood pressure drops, when
Yeah.
there's a neurogenic shock, the body can't compensate. That's why we are supplementing with a vasoconstrictor and a inotrope.
Right. Right. So
But if it's bleeding, the body can. So the tachycardia in this
okay.
question, sir, won't it favor intra-abdominal bleeding?
Yeah, it does. But the thing is that it does. But the thing is that all these details are given. Say like signal pinter and GCS, quadriparesis, all these things in an MBBS level, what they are trying to find out is in this particular MCQ, it's not going into the details of arguing between intra-abdominal bleeding and spinal shock. These details are given. Quadriparesis is specially given to test your knowledge on neurogenic. So I think best thing is this type of thing. Either it's a best of 5 answer, you just drop it, because dropping it you get 0. If you mark it wrong, also you will get 0. So, but we don't know. I think, but my feeling is that at a MBBS level, all these surrounding clues are given for you to think more in terms of neurogenic. So don't go into only one area of this pulse rate, high pulse rate. And there's no rule to say that neurogenic shock, now the spinal cord injury people, they all don't have bradycardia. So sometimes their pulse rates are normal. Then the sympathetic outflow coming from the brainstem, it doesn't get completely, it's not gone. So the compensatory mechanisms are still there in partial injuries. So this clue is an isolated clue, isolated thing. I think I agree with you that when we are making MCQs, this type of ambiguities nowadays completely eliminated. We don't MBBS level. We don't put this type of ambiguous. This is ambiguity. Ambiguous clues we don't put anymore. This is one of the old questions. But this type of situation, think about the whole picture. And what they are trying to find out is what is the best treatment for neurogenic shock. Okay. 50-year-old woman presenting with lethargic wall intolerance and atrial fibrillation on examination. I think we have to finish in another few minutes. Presenting with lethargic wall intolerance and atrial fibrillation on examination. Which of the following complications can occur? Cerebellar degeneration. What is the clinical situation is? What is this clinical scenario here?
Hypothyroidism.
Yeah, hypothyroidism or mixed edema, isn't it? So, cerebellar degeneration is not a known complication. Why? They have given it as a distractor most probably because cerebellar ataxia in long-term mixed edema, you can get cerebellar ataxia due to malfunctioning of cerebellum, but it is not due to, now histologically there is no degeneration. So mixed edema can lead to cerebellar ataxia, but not cerebellar degeneration. So that answer has to be false. Macrocytic anemia. Is it an association or not with hypothyroidism? Yeah, I think this is a difficult one. It is a known, apparently it's a known combination, known association to get macrocytic anemia due to pernicious anemia. That is autoimmune atrophic gastritis with vitamin B12 deficiency. So, and also there is some impaired erythropoiesis in chronic or long-term hypothyroidism. So the time period is not given, but he has developed cardiac complications, obviously. So it has to be a long-term hypothyroidism. But just remember that this is theory. Macrocytic anemia is a known complication, known association, because it is generally secondary to autoimmune gastritis. External ophthalmoplegia, true, false?
It's in hyperthyroidism, sir.
Yeah. Hyperthyroidism, as I mentioned in one of the previous MCQs, ophthalmoplegia, paralysis of eye muscles, is associated with hyperthyroidism. So this is hypothyroidism, so that is obviously wrong. Myocarditis, you get myocarditis in myxedema or hypothyroidism. It's not a known complication. Again, these are called distractors. You can get in hypothyroidism, you get bradycardia because thyroxine deficiency, and you can get pericardial effusions, but not myocarditis as such. So this is wrong, obviously. And confusion and coma. That happens in that is
Myxedema does coma.
yeah, it's called myxedema coma. Myxedema coma. It's a standard terminology. What happens is long-term thyroxine deficiency leads to confusion and cold intolerance, that is hypothermia, bradycardia, and they get also respiratory problems, depression, and altered mental status and croaky voice. Most of the time, myxedema is diagnosed, good old days, diagnosed through the voice. The phone call can make the physician to diagnose it. And myxedema coma is life-threatening emergency. So just that is confusion and coma is part of the myxedema, and it's an emergency. Just remember that. 40-year-old man, the last question probably for today. 40-year-old man presented with constipation, abdominal distension, lower GI endoscopy, or lower GI endoscopy normal, and potassium levels were low, and possible underlying causes. Yeah. This is constipation, abdominal distension, and lower GI doesn't show anything, and potassium levels were low. This is probably endocrine surgery question. So how do you mark these? Can it be Addison's disease? What is Addison's disease?
Adrenal tumor, sir.
You think it's an adrenal tumor? Yeah, okay. Let's see. That's possible, adrenal tumors, because sometimes adenomas can hypersecrete or hypersecrete aldosterone, and then lead to what we call Conn syndrome. Okay. Conn syndrome will lead to loss of potassium and hypokalemia, hypokalemia, low potassium can lead to constipation and myalgia and muscle weakness and fatigue. So that is possible, but that is aldosteronoma, or what we call the aldosterone secreting adenoma. That's possible. So then Addison's disease is what? Is it possible?
No, sir.
Why not?
Because their aldosterone level is no low, sir.
Yeah, Addison's is the opposite of Cushing and Conn. That means the adrenal failure. So except the adrenal medulla, the adrenal cortex fails in Addison's. So because that aldosterone goes down, and then it leads to potassium retention. That is hyperkalemia. So this is hypokalemia, so Addison's is out. These changes in adrenal hormones. You have to be thorough with, because generally there is one question. Renal artery stenosis.
Also, because there's hyperkalemia. Due to
What?
RAS activation, there's hyperkalemia.
Yes, but now actually speaking, if renal artery gets stenosed, what will happen? There will be secondary kidney thinks that its blood supply goes down, and it leads to increased secretion of. It thinks that the pressure has dropped. This is what happens in renal artery stenosis. When the blood doesn't come to the kidney thinks that the pressure has dropped and it is not sending any blood to the kidney. So what happens is it starts secreting aldosterone and leads to hyperaldosteronism, and then that can cause hypokalemia and hypertension. But now this says there is GI symptoms. Renal artery stenosis has nothing to do with GI. The first part is right. It can cause hypokalemia and hypertension because there is no enough blood coming to the kidney. And GI symptoms exclude the possibility of renal artery stenosis. Other two are correct. So on those features, we have to make it wrong. And then adrenal tumors, true, because remember it's Conn syndrome. One of the causes of Conn syndrome is primary hyperaldosteronism. Is aldosterone secreting adenoma, or sometimes hypertrophy of adrenal cortex. And that will lead to more aldosterone means hypokalemia. Okay, so I can explain all these things. So that is the most appropriate answer if it is the best of 5. Then Cushing syndrome. What is the Cushing syndrome? It is not aldosterone. It is the excess cortisol. So that is the cortisol secreting part of the adrenal cortex get hypertrophy. So what is the effect of cortisol on potassium? The cortisol also has, I think you must remember, if you remember your physiology, it has partly mineralocorticoid, that is aldosterone-like effect. It has a similar effect. So it increases the potassium excretion like aldosterone, and it also can lead to Cushing syndrome, also can lead to hypokalemia. But again, you can get GI symptoms also in Cushing syndromes due to smooth muscle weakness and low gut motility, which is again a known feature of Cushing's. So when you take Cushing's, these findings tally with it. So if it is a true or false one, adrenal tumors and Cushing syndrome both are true, but because of that mineralocorticoid-like effect of cortisol. But if it is a best of 5, I would rather go for, because no other features of Cushing syndrome, Cushingoid phases or anything is given, I would go for adrenal tumor. But true, false, C and D are both. And thyrotoxicosis, is it possible? It can cause diarrhea, and it can cause increased gut motility and things. But it has nothing to do with potassium. Thyrotoxicosis has no connection with potassium levels. So because of that, that is wrong. So that will be false. So yeah, this is the answers. So I think we will stop at this. And some of you all must be facing the MCQ on the 18th, no?
Yes.
Yeah. So I think we'll try to have a couple of classes, try to cover certain areas, try to make a combination of blueprinted MCQ paper, but don't expect everything to come. But I'll get a combination of it and we'll quickly try to run through it before the MCQs. Okay then. So that's all for today. All the best then. Good night.
Thank you,
Good night,
sir.
sir. Yes, sir.
Thank you, sir. Good night.
Okay, good night.